I'm your host, Adrian. We do content like this weekly, so hit the subscribe button and ring the bell to get notified. If you want more content like this, click the like button and please leave a comment. Thanks again for watching. And welcome to today's Rupa University live class presented by Rupa Health, the simplest way to order specialty lab work. My name is Adrian Martinez, and I'll be your host for this afternoon. Today, we have a very, very special guest in Dr. Pamela Smith, here to provide a comprehensive evaluation of adrenal fatigue in the clinical practice, along with Access Medical. So before jumping in, a couple of quick housekeeping items. Everyone joining will be muted by default, but don't fret. If you do have any questions, please drop them in the chat box, or use that Q&A button down below, and we'll host a live Q&A session at the end of the presentation. Immediately following the Q&A, yours truly will show you exactly how to order these tests right on Rupa Health. So stick around if you're not familiar with our platform and how you can easily order Access as well as 25 plus different labs in one spot. And then if you have to jump early, no worries at all. We will be sending out a recording of the session along with the slides within the next few days. And additionally, if you're a fan of this type of content, be sure to check out rupahealth.com to get access to all the previous sessions that we've done along with those slides. So with that, let's go ahead and jump in. I'd like to introduce Dr. Pamela Smith, who spent her first 20 years of practice as an emergency room physician with the Detroit Medical Center in a level 1 trauma center, and then an additional 28 years as an anti-aging functional medicine specialist. She's a diplomat of the board of American Academy of Anti-Aging Physicians. She holds a master's in public health degree, along with a master's degree in metabolic and nutritional medicine. She's been featured on numerous television programs and is the author of 11 best-selling books, including the recently released What You Must Know About Women's Hormones, 2nd edition. So with that, thank you so much for joining us, Dr. Smith. I'll go ahead and let you jump in from here.
Perfect. Thank you so much. Hello, everybody. And those of you who know me know that hormones are one of my very favorite subjects to talk about. So today we're going to look at adrenal fatigue in clinical practice, along with looking at thyroid and its relationship. When it comes to the adrenals, we look at DHEA and cortisol, and DHEA is made by the adrenal glands. A small amount is also made in the brain and skin. DHEA production declines with age starting in the late 20s, so that by the time that people are 70, only about 1/4 the amount of DHEA is made. It does make estrogen and testosterone in the body. So if someone has a hormonally related cancer, such as breast or prostate, then we don't give them DHEA since it does make those hormones downstream. And DHEA levels change at any age if someone is stressed. Most of you know the functions of DHEA. It is the sense of well-being. It helps being a hormone of repair. It helps with allergic reactions, weight loss, bone building, even decreases cholesterol. This study reviewed the functions of DHEA. In the elderly, it actually exerts an immunomodulatory effect. It increases the number of monocytes, T cell suppressing T cell receptor gamma delta, and natural killer cells. In adrenal insufficiency, DHEA, when it's given, restores all of these functions in the body. Plus, very importantly, it is anti-inflammatory. Every disease that a patient can get after the age of 40 is inflammatory in nature. DHEA also modulates cardiovascular signaling. Anti-inflammatory effect is there. It's correlated with an increase in cardiovascular disease and all-cause mortality if DHEA is low. And DHEA has a protective effect in asthma and allergy as well. Even infertility, vaginal atrophy, it has many functions in the body. How does a patient have low DHEA? Menopause or andropause, decreased production overall, of course, stress, aging, and smoking. Nicotine inhibits the production of 11-beta hydroxylase, which is needed to make DHEA. Replacement of DHEA does many things. It increases muscle strength and lean body mass. It activates immune function, increases the quality of life, improves sleep, increases feeling of wellness, decreases joint soreness, increases sensitivity of insulin, lowers triglycerides, stops the damaging effects of stress, elevates growth hormone, and it has a positive effect on memory. Is there any medication that we can think of that does everything that this hormone does? The doses are much smaller until the patient gets to be about 65 that are needed in women than men. Also, if you're reviewing the medical literature, they do use DHEA for people with rheumatoid arthritis, lupus, and other autoimmune diseases, but there the dosage is higher. It's 100 to 200 milligrams. Today, we're looking instead at hormonal balance. A recent study showed that patients that use statin drugs have lower sex hormone binding globulin levels and lower DHEA than controls. Very interesting. Based on limited available evidence, DHEA supplementation seems to improve ovarian reserves, and it does help with poor ovarian response. Now, you can have too much of a good thing. You can have too much DHEA. I call all of this going postal. So the patient can have too much from stress. They can also have too much if they are prescribed too much DHEA. And then they will get all these things from acne to sugar cravings, irritability, etc. Cortisol is the hormone that balances, and it is all about balance when we look at hormones and many other things in the body. Cortisol balances blood sugar. It has to do with weight control, immune system response, bone turnover rate, stress reaction, sleep, protein synthesis, mood and thoughts, balances the other hormones, and anti-inflammatory. What elevates cortisol? Stress, stress, and stress, but also depression. High progestin intake can, meaning synthetic progesterone, sodium depletion. If prolactin goes up, then that can elevate cortisol, inflammation, Cushing's, and obesity itself. If cortisol levels are too low, how does that happen? Chronic stress. When patients are first stressed, cortisol elevates. When they've been stressed for a long time, it becomes too low. The patient has to have cortisol to live. If they don't have cortisol, they die in 7 days. So if you go back and look at the steroidogenic pathway, pregnenolone makes estrogen, progesterone, testosterone, DHEA, and cortisol. But pregnenolone will preferentially, at any age, make cortisol to keep the patient alive. So chronic stress is the #1 reason. Addison's, of course, opioid use can make cortisol too low. Chronic marijuana use, steroids, and Accutane. Do not forget clinical pearl. The body's total cholesterol has to be at least 140 to make pregnenolone to make these other hormones. Sometimes cardiologists forget this, and they get the total cholesterol so low that it doesn't make any of the rest of the steroidogenic pathway. Consequences of elevated cortisol: a compromised immune system. Of course, this is a big issue in today's world with COVID and all its variants. An increase in bone loss. You can do everything for the patient. They can do everything from exercise to avoiding alcohol, to hormones, to nutrients, to build bone. However, if they stay stressed, most patients will still have bone loss. Other consequences of elevated cortisol: fatigue, irritability, sugar cravings, shakiness between meals, confusion, memory's not as sharp. Patients will say they have brain fog, low energy, night sweats, binge eating. The blood pressure goes up, cholesterol, blood sugar, triglycerides all elevate. The patient can even develop insulin resistance. They do have an increase in developing infections, thin skin, easy bruising, muscle weakness, weight gain around the middle, sleep disturbances, and impaired hepatic conversion of T4 to T3. So if the patient stays stressed, then the thyroid, the body regulator, does not work as well as it could. A lot of different diseases are associated with abnormal cortisol levels. I listed a few here for you. Here are some more. When patients are first stressed, again, cortisol goes up. They've been stressed for a long time. It's too low. How do you treat this? The next few slides go through this, but initially the treatments are the same. First of all, we want to do a saliva test to look at where cortisol stands. There are 6 tests that are looking at all of this from the viewpoint of clinical trials. And those clinical trials all show the same thing. Cortisol should be measured by saliva testing. And I like to do a 4-point cortisol, where I look at cortisol at 8 in the morning, 12 noon, 4 to 5 p.m., 10 to 11 p.m., because that gives me a better idea as to what goes on. So first of all, you have to measure cortisol correctly to know how to treat it. So salivary testing is key. Then when we look at DHEA and cortisol, if it's too high or too low, stress reduction techniques, prayer, meditation, Tai Chi, yoga, Qigong, exercise, massage, breathing techniques, all of those things are very, 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 very important. When we look at adaptogenic herbs, those are used when cortisol is too high or too low. So ashwagandha, ginseng, rhodiola, calming herbs, if the patient is stressed and wired, like chamomile, lemon balm. If the patient's low in DHEA, then replace it. But there is a caveat, major clinical pearl. If you give DHEA and cortisol is not normal, and you don't also give adaptogenic herbs and things to support cortisol, the next time that you go back and you measure DHEA, even though you're giving it to the patient, it will actually be lower if you don't give the adaptogenic herbs, stress reduction techniques, etc. If cortisol is high in the PM, then you can add phosphatidylserine, and that can be very beneficial for the elevation of cortisol at nighttime. Also, a multivitamin. These nutrients are important for the adrenal glands to work. So again, high and low cortisol treated the same initially. If cortisol stays low, then take the patient off of adaptogenic herbs or adrenal and give them adrenal extracts. They're purified, so you don't have to worry about them, and calming herbs. If cortisol stays low, then licorice, the herb, not the candy. Do not give licorice to people with hypertension. If they develop hypertension on licorice, then take them off. Cortef is the last resort. Please do not start with Cortef. The medical board everywhere in the world will not favor you if you start with Cortef. Go back and give the multivitamin, stress reduction technique, adaptogenic herbs, etc., in order to help the patient. If they're then not healthy, then Cortef. And you want to augment, not replace. What does that mean? You have to stay at 20 milligrams or under for augmentation. So that's the important key. I usually give it the following way, because the body makes more cortisol in the morning, 7.5 milligrams in the AM, 5 milligrams at noon, and 2.5 milligrams at 5 p.m. So 7.5 milligrams in the AM, noon 5 milligrams, the afternoon 2.5 milligrams. It's usually given for 6 to 9 months, should not be given for more than a year. If you're going to consider that, then please have an endocrinologist working with you, and do not stop Cortef abruptly. The patient does need to be weaned off over about a month's period of time. I actually leave the patient on adrenal extracts while they're on Cortef, so that when we're weaning them off, they have something for the body to go back to. So when we go back and look at some of the issues that happen with low cortisol, what are the symptoms? Fatigue, low blood pressure, sensitivity to light, insomnia, digestive problems, Emotional imbalances, lack of motivation is a common symptom. Hypoglycemia, decreased sexual interest, compromised immunity, lack of stamina, emotional paralysis, poor wound healing. There is an increase in alcoholism and drug addiction, allergies. The patient can get unresponsive hypothyroidism, meaning you give them thyroid medicine and it does not work. And patients commonly feel very overwhelmed. How does a patient have too much or too little cortisol? Long-term stress, but also nutritional deficiencies, dysbiosis. The gut's not healthy, too much bad bacteria and not enough good, chronic inflammation, chronic pain, toxic exposure, overly aggressive exercise, meaning they exercise 7 days a week, but they don't replenish nutrients, hypoglycemia, poor sleep hygiene, depression, and severe allergies. The hormones really are a web. So if cortisol's increased, it decreases the making of progesterone and its activity. Cortisol does compete with progesterone for common receptor sites. And when cortisol's high, thyroid is more bound and less active. By the way, when we look at female hormones, if her estradiol level is low and we don't replace it, it is a stressor to the body and it makes cortisol levels abnormal. So that's what happens with cortisol and looking at the different kinds of therapies. Let's now center on adaptogens themselves. There's adaptogens for chronic stress and adaptogens for what happens with stress that is long-term. Plant adaptogens are compounds that increase the ability of an organism to adapt to environmental factors, to avoid damage from these factors. The beneficial effects of multi-dose administration of adaptogens are mainly associated with the hypothalamic pituitary adrenal axis and part of the stress system that's believed to play a role in the reactions of the body to repeated stress and adaptation. So what are the different therapies that can be used for chronic stress for adaptogenic herbs? Ashwagandha, bacopa, cordyceps, and holy basil. Each of these herbal therapies has a different mechanism of action. The thyroid has an interplay with this system. So hypothyroidism is defined as low thyroid function or underactive thyroid, where the thyroid gland does not make enough thyroid hormone to allow the body to function optimally. The main function of thyroid hormone is to oversee the metabolism in the body. When the patient is hypothyroid, it destroys the normal equilibrium of the chemical reactions in the body. And the earliest signs and symptoms of low thyroid function can occur several years prior to lab results being abnormal. What are some of the signs and symptoms of low thyroid production? Depression. No one should end up having a real evaluation and being put on an antidepressant unless they've had thyroid functions done first. Weight gain, constipation, headaches, including migraines, brittle, ridged, striated, thickened nails, rough, dry skin, menstrual irregularities, fluid retention, poor circulation, elbow keratoses, slowed speech, nails that are easily broken. Anxiety and panic attacks can be a symptom of low thyroid production. Decreased memory, inability to concentrate, muscle and joint pain, reduced heart rate, morning stiffness, puffy face, swollen eyelids, decreased sexual interest, cold intolerance, cold hands and feet. I hope you're thinking of your patients as we go through here. Slow movements, swollen legs, feet, hands, abdomen, insomnia, fatigue, low body temperature, husky, hoarse voice, low blood pressure, yellowish discoloration of the skin, and the inability to convert beta carotene into vitamin A, muscle cramps, droopy eyelids, even carpal tunnel syndrome. Before someone goes to surgery, they should have their thyroid evaluated. Sleep apnea, endometriosis, high cholesterol, infertility, PMS, hyperinsulinemia. There are a lot. A downturned mouth is really pathognomonic. Acne, allergies, painful menstrual cycles, tendency to develop allergies, loss of lateral 1/3 of the eyebrows is pathognomonic. That is called the Queen Anne sign. Fat pads above the clavicles. I was actually teaching about thyroid at A4M in one of its modules, and I had someone come up to me and she said, "Can you come to the bathroom with me?" And I thought, well, okay. And she showed me her clavicles. There were fat pads. She goes, "Is this what you're talking about?" I said, "Absolutely. Go home and look at your thyroid studies." She called me back. She didn't know she was hypothyroid. Hair loss in the front and back of the head, paresthesias, myxedema, nutritional imbalances. I mean, thyroid is everything. Loss of hair in varying amounts from legs, axilla, and arms, poor night vision, loss of eyelashes or eyelashes that are not as thick. Blepharospasm is more common. An ear canal that is dry, scaly, and itchy, and also it may have excess formation of cerumen. Fibrocystic breast disease, I think two things, or actually three. I think low iodine. I think, where is the thyroid? Are they hypothyroid? And then, of course, we want to look at hormonal balance and do a saliva test and make sure the estrogen and progesterone ratio is correct as well. Muscle weakness, iron deficiency anemia, B12 deficiency. Those patients that you give B12, you give iron to, it doesn't seem to fix. Go back and look at thyroid. Tinnitus. Tinnitus is such a hard one. People get ringing in the ears. I do give low-dose naltrexone for tinnitus. Sometimes that's helpful. Also, there's a great study looking at different herbal therapies that can work for tinnitus, but I only get about a 30% effective rate until I started looking at the thyroid. Delayed deep tendon reflexes, low amplitude of theta and delta waves, bipolar disorders, schizoaffective disorders, miscarriages. Yes, there's more. Dizziness, congestive heart failure, heart disease, decreased cardiac output, arrhythmias, increased risk of developing asthma, mild elevation of liver enzymes, dull facial expression, sparse, coarse, dry hair, agitation and irritability, gallstones, bladder and kidney infections. I think you're getting the hint. Everybody needs thyroid studies done. Eating disorders, increased appetite, deposition of mucin in the connective tissues, muscular pain, high homocysteine, high C-reactive protein, hypertension, joint stiffness and arthralgias, menorrhagia, recurrent miscarriage, nocturnia, easy bruising, erectile dysfunction, hypoglycemia, shortness of breath, impaired kidney function. I actually have these all printed out on a handout that I give the patient. I have them circle their symptoms, and then I put it in my electronic medical records. If you would like a copy of my handout, I'm happy to share it. Please email me at faafm63@yahoo.com. So faafm63@yahoo.com. So all these references are related to this. Adrenal dysfunction and primary or secondary hypothyroidism may occur together, and people may actually get adrenal cortex antibodies as well. Cortisol levels may elevate to compensate for low T3 levels. So sometimes that cortisol goes up that we were talking about because we didn't look at thyroid. The biggest clinical pearl of today is right now. Always, without exception, please do not break this rule. Always fix cortisol by starting the stress reduction techniques, the adaptogenic herbs. Do those for 6 to 8 weeks before you consider putting the patient on thyroid medication. Otherwise, if you do it together or you start with thyroid and you don't fix adrenal, the patient can get symptoms of hyperthyroidism, such as headache and heart racing. And when you do the labs, they're not hyperthyroid, but they get those symptoms because you didn't deal with cortisol first. And that's why we're doing the seminar today. These two hormonal systems, the adrenal and thyroid, go hand in hand, and they have to be balanced. So always fix cortisol for 6 to 8 weeks, meaning working on it. It takes a year to fix it. Then go back and give thyroid medicine if needed. Thyroid hormones, the body does make T1, T2, T3, and T4. These factors cause a decreased production of T4, deficiency of zinc, copper, vitamins A, B2, B3, B6, and vitamin C. Also, you want to convert T4 to T3. T3 is 5 times stronger than T4, so it is the more active component. This does require 5' deiodinase, of which there are 3 types. These elements affect 5' deiodinase production, selenium deficiency stress, cadmium, mercury, and lead toxicity. So I do a lot of toxic metal testing, starvation, inadequate protein intake, high carb diet, elevated cortisol, chronic illness, and decreased kidney or liver function. Inflammation is a huge one. Other factors that can affect the ability to convert T4 to T3 are nutritional deficiencies like iodine, iron, selenium, zinc, vitamins A, B2, B6, and B12. So it does benefit you to also do nutritional studies. I do on all of my patients. Medications can cause a negative conversion. And so the ability to convert T4 to T3 can be impacted by beta blockers, birth control pills, estrogen. Estrogen depletes the body of some of the Bs. If you give those B vitamins, then it does not negatively impact the conversion. Lithium, phenytoin, theophylline, some of the chemotherapeutic agents, and more. Glucocorticoids, interleukin-6, clomipramine. And of course, you can have too much of a good thing. Too many cruciferous vegetables, broccoli, Brussels sprouts, kale, cauliflower, can negatively impact the conversion of T4 to T3, as can low protein diet, low fat, low carb, excess alcohol use, too many walnuts, and too much soy. The aging process, this is one that people don't know as much about. From Bert Bergson's work and others, excess alpha lipoic acid. Dr. Bergson showed that at 600 milligrams of ALA, alpha lipoic acid or more, it can negatively impact the conversion to T4 to T3. Have I seen this? I actually have. From Bergson's work, you can treat looking at hepatitis C with alpha lipoic acid, and about 1/3 of people are cured. I had a nurse who came to me early on when there was only one drug that would treat hepatitis C. She had an allergy to that drug, so she wanted to know what else we could do. We gave her 600 milligrams of ALA twice a day, and honestly, it was so exciting. We cured her hep C, but we did make her hypothyroid. So be aware of that. You know, for most things, 300 to 400 milligrams of alpha lipoic acid is fine. Other things on the conversion of T4 to T3, diabetes, fluoride, lead, mercury, pesticides, radiation, stress, surgery, and copper excess. Calcium excess, as you know, you can get toxic in calcium, but one of the toxic effects are a decreased conversion of T4 to T3. Dioxins, PCBs, which you can measure phthalates, and of course, an adequate production of DHEA and cortisol. There are factors that are associated with low T3 or increased reverse T3. When you measure thyroid, it's imperative to get a TSH, a free T3, a free T4, a reverse T3, and thyroid antibodies. You're really not getting complete studies unless you measure all of those. So these factors that are associated with low T3 or a high reverse T3, increased epinephrine and norepinephrine, free radical production, the aging process, fasting, stress, prolonged illness, diabetes, toxic metal exposure, and inflammation. These factors can increase the conversion: selenium, potassium, iodine, iron, zinc, a higher protein diet, and the herb ashwagandha. Yes, ashwagandha is an adaptogenic herb. We mentioned it there. It does increase the conversion of T4 to T3. It's also a great herb for memory. Other things to increase the conversion: vitamins A, B2, E, growth hormone, testosterone, insulin, glucagon, melatonin, tyrosine. I don't recommend the last one. Don't overdose estrogen. Hashimoto's thyroiditis. There's a number of chemicals that can lead to Hashimoto's thyroiditis. And when it comes to women, 70% of women who have hypothyroidism actually have Hashimoto's. So perchloride, fluoride, lithium, mercury, bisphenol A, and Teflon can be an etiology of Hashimoto's. Excess iodine is problematic, so you should measure iodine. Too much iodine can lead to thyroiditis and an increase in thyroid cancer. Pregnancy does create hormonal changes in a woman's body, so go back and look at that as well. And radiation exposure can be a cause of Hashimoto's thyroiditis as well. And there's a genetic component too. Here's all the studies I was talking about. So that TSH, free T3, free T4, reverse T3, and thyroid antibodies. Some people, you'll still need to do a basal body temperature, but I always do lab thyroid studies also. Basal body temperature is the temperature under the arm for 10 minutes for 3 days before arising. If the patient is cycling, then take the temperature during her menstrual cycle. How do we treat all of this? Detoxification. If the patient has PCBs, dioxins, if they have toxic metals, then remove the toxin. That will help with the hypothyroidism. When we look at T4 and T3, T4 has very little physiological activity. T4 must be converted to T3 to be utilized by the cells, and the conversion takes place in the liver and the kidneys. As we mentioned, T3 is 5 times stronger than T4, and there's never been a long-term study to show that T4 effectively treated the symptoms of hypothyroidism. Shocking, but it's true. Intracellular thyroid hormone receptors have a high affinity for the T3. In fact, 90% of the thyroid hormone molecules that bind with the receptors are T3, and only 10% are T4. If the patient's not able to metabolize thyroid, they will not be as healthy. So most people, in fact, one clinical trial showed that 98% of people need both T3 and T4. 2% of people just need T4. There's a few people that just need T3. I go according to lab results. I had a patient recently that was very upset at me because she came to me because she wanted armothyroid. She wanted T3 and T4, but guess what? She only needed T4. And it took me an hour and a half to explain to her why I was only giving her T4. She was one of those few people that didn't need both. But most people do need both. Desiccated thyroid is both T3 and T4. So if you look at all of the different kinds of thyroid that are prescribed, we're going to go through those. Just to mention, T3 has a direct effect on the mitochondria and has a direct effect on the heart. So these are the T4s that are available in North America. Synthroid is the dispense as written, meaning non-generic. These are the T3s. They're very immediate release. I don't have any patients on any of these because they get released so quickly in the body, you would usually have to give most of them twice a day. Desiccated thyroid, from Armour to the different other kinds of thyroid, are made from porcine. Most of them are close to ratios of 4 parts T4 to 1 part T3. There's one medical trial that suggests that if the patient has Hashimoto's thyroid, thyroiditis that you should not use desiccated thyroid. I don't know if I agree with that or not. I honestly have not had a problem in all of these years of using desiccated thyroid in people that have positive thyroid antibodies. But that one study is out there. So I've moved more and more toward looking at compounded thyroid that's non-desiccated. Also, when you compound something, you can make it any ratio you want it to be. You can make it T4 to T3, 1 to 1, 10 to 1, 20 to 1. But I do use desiccated thyroid. That's one way of doing T4 to T3. The compounded, you can also add selenium, chromium, zinc, and iodine if you would like. And in this study, lab results were not improved, but the patients felt better when they took both T3 and T4. We want the TSH to be optimally below 2. And people above 70, I use 2.5. In anti-aging medicine, we did this study many years ago, looked at 80,000 people, and we found out that the healthy person, TSH was 1.5. So we set our normals, TSH at 2 as the upper limit of normal. In 2004, the endocrinologist joined us. They discovered that our anti-aging patients were doing better because we like optimal function of thyroid hormone. And so in 2004, the endocrinologist set their upper limit of normal at 2.5. It has changed over time. We like the free T3 to be dead center of normal, the free T4 to be dead center of normal. The reverse T3 is a problem if it's high normal or high. So even high normal reverse T3 can be problematic. And recent studies have shown that it's now time, don't you love this, for a personalized approach to thyroid replacement in patients. When we look at elevated reverse T3, high normal or elevated levels indicate reduced thyroid transport so that it really doesn't get into the cell well. This is usually due to a mitochondrial dysfunction. So any disease process associated with mitochondrial dysfunction can be associated with high normal or elevated reverse T3. Lots of references to that. So what are these diseases? Insulin resistance, diabetes, obesity, chronic and acute dieting, depression, anxiety, bipolar depression, neurodegenerative disorders, the aging process itself, chronic fatigue syndrome, fibromyalgia, migraines, chronic infections, cardiovascular disease, inflammation and chronic illness. Boy, that covers a lot of people. High cholesterol, high triglycerides. You can see why I say that it's imperative to measure reverse T3. When you look at elevated reverse T3, the transporter for T4 is more energy dependent than the transporter for T3. And cellular levels of thyroid are not detected well by serum T4 levels, since T4 is transported into the cell, and the lower the cellular level of T4, the higher the serum level. So you can't go by just TSH, you can't go by just TSH and free T4. The most important determinant of thyroid activity is the intracellular T3 level. And high normal or elevated reverse T3 levels are the best measurement of thyroid transport into the cell. So look at free T3, reverse T3 as part of this. What do you do if reverse T3 is high? Because it inhibits the conversion of T4 to T3. Free T3 and reverse T3 occupy the same receptor sites. However, T3 will activate the receptor site, reverse T3 does not. If reverse T3 is high, the patient will have symptoms of hypothyroidism, even if the labs are normal. I'm going to repeat that. If reverse T3 is high, the patient will have symptoms of hypothyroidism, even if the labs are normal. Since reverse T3 is derived from T4, they'll lower the T4 dose or take them off and give T3. What else can you do? Eliminate stress, growth hormone if needed, that would be the last resort. If selenium and iodine are deficient, give those. Treat infection if present, And this, again, is commonly a mitochondrial problem. So how do we fix a mitochondrial problem? Write this down or type it into your tablet. Magnesium, 400 to 600 milligrams a day. I usually give glycinate or threonate. Coenzyme Q10, 300 to 400 milligrams. Alpha lipoic acid, 300 to 400 milligrams. L-carnitine, 1,000 to 2,000 milligrams. That's with normal renal function and normal TMAO. Please always measure TMAO levels before you would ever supplement with carnitine or choline. NADH, 10 milligrams twice a day. And lastly, D-ribose, 15 grams. It's a powder, usually 1 teaspoon. So it's 5 milligrams per teaspoon. So 15 a day. And that is 15 grams. So 5, 5, and 5, TID. This study showed that plasma T3, not plasma T4 alone, permit the production or prediction of the degree of change in T4 and T3 in the tissues, and the practice of replacing T4 alone is considered inadequate. Another trial showed that even a small decrease in cellular ATP resulted in a major reduction in the transport of T4 and reverse T3, but only slightly affected T3 uptake. The study concluded it's not appropriate to use T4 alone for thyroid replacement in any disease that involved mitochondrial dysfunction. This trial revealed the combination of T3 and T4 normalized the levels of T3 in the tissues. These medications affect the clearance, so be aware of that. Dilantin, Tegretol, phenobarb, and tamoxifen. Also rifampin, retinavir, and citrulline. Iodine is very important. The body does require iodine for the thyroid to work well. 89 patients that were hypothyroid, treated with T4 previously, compared to a group of patients with low thyroid that were untreated. In this study, the symptoms of the patients already on T4 were not different from the people who were untreated. In other words, whether they took thyroid medicine or not, if they only took T4, didn't matter. Always consider when you're giving the thyroid. Treat adrenals first. If the patient starts to feel more fatigue when the thyroid dosage is indicated or it's increased, there's indicative of adrenal fatigue. So back down a little bit. If the patient just had an acute MI, you probably shouldn't start thyroid the next day. Make sure the gut's healthy, particularly if you're going to use extended release thyroid hormone. And low magnesium levels may interfere with the patient's ability to tolerate thyroid replacement. It's more likely that the patient will have heart racing and irregular heartbeats. Chronic exposure to mold may interfere with the patient's ability to tolerate thyroid replacement. So iodine, please measure. Iodine has all of these actions in the body. Most people are deficient in iodine worldwide, and the US Institute of Medicine recommends a daily intake of 150 micrograms of iodine. The upper limit of normal is listed on the slide for you. And there's the 72% of the world's population is deficient. Causes of iodine deficiency are numerous. Ground deplete, diets are deplete, diets high in pasta, and medications that contain iodine or fluoride, bromide, all those things will cause iodine deficiency. Iodine deficient and thyroid replacement, again, what's best here is the following. Measure iodine first, then give thyroid replacement if needed. A small percentage of people only need thyroid medicine if they have no deficiencies. So a few people, if you just replace iodine, what happens? They don't need thyroid hormone. So do be aware of that. Also, if they're already on thyroid hormone, you measure iodine levels, they're low, you give iodine, then you may have to back down on the thyroid dose. And here's your references on overtreatment with iodine that I mentioned earlier. It's also important to have iron. Ferritin levels should be measured. A normal ferritin should be 100 for men, and for menopausal women, ferritin of 130 for women who are cycling. Soy can inhibit thyroid function. Selenium is needed for thyroid function. Zinc supplementation is as well. And some people have thyroid resistance, where not only can it be a mitochondrial problem, but 100 different mutations have been found that affect thyroid receptors. There may actually be mitochondrial defects as well. So a lot of diseases are associated with hypothyroidism. I put some of them here for you. So let's look at the medical literature. ADHD. Some studies have shown that ADHD is very common. These people have low thyroid function. Elevated CRP levels are associated with hypothyroidism. High homocysteine. Hypothyroidism is a risk factor for cardiovascular disease. In this study, a low ratio of T3 to reverse T3 was a predictor of mortality in congestive heart failure. They actually gave IV T3 in advanced congestive heart failure, and there was an increase in cardiac output and a decrease in systemic vascular resistance. Here, VTAC associated with low T3 or low T3, T4, and increased reverse T3, and low T3 predictive of an increase in AFib post-coronary artery bypass graft. Low T3, a strong predictor of death in cardiac patients. It's also associated with arterial stiffness. Elevated reverse T3, strongest predictor of mortality in the first year post-acute MI. Don't you wonder why everyone does not look at reverse T3? I do. T3 improves depression in this study in patients with post-traumatic stress disorder. Chronic fatigue and fibromyalgia. At least 95% of these patients are hypothyroid. Ankylosing spondylitis. Here, insulin resistance, lower TSH, and higher T4 are associated with improved insulin sensitivity, higher HDL, and better endothelial function. And of course, memory. If the hormone that regulates the whole body is not functioning optimally, of course, memory is not going to be as sharp. And this study did show that optimal TSH levels were important to maintain memory. In this trial from 2017, this study revealed the most important contributors for the development of small intestinal bowel overgrowth in ascending order are immunosuppression, impairment of intestinal clearance, and whether they had normal thyroid function or not. Some studies suggest that porcine thyroid is, again, not the appropriate therapy for people with Hashimoto's, and celiac disease is being investigated as being related to Hashimoto's. One autoimmune disease tends to beget another. A gluten-free diet. So when you look at Hashimoto's, like any autoimmune disease, 3 things: no gluten, fix the gut, low-dose naltrexone. Low-dose naltrexone is probably one of the biggest medicines in my 44-year career that has changed medicine. It's not the usual high dose that we use for drug overdose, but in low dose, it has different functions. And one of those is a major anti-inflammatory. If you're not familiar with LDN, the most common dosing schedule, and it is compounded, is 1 capsule of 1.5 milligrams an hour before bedtime the first week. Then they take 2 capsules for 3 milligrams the second week. The third week, 3 capsules, so they're on 4.5 and 4.5 milligrams thereafter as a single capsule. Some people cannot tolerate 4.5. I have a number of people that I end up backing up and they just take 3. Potential short-term side effects: insomnia, most common, also vivid dreams, fatigue, loss of appetite, nausea, hair thinning, mood swings, mild disorientation. There can be long-term side effects although everything listed on the slide so far, and I've been using LDN for many years, I have not seen. There are counterindications: alcohol ingestion that is abuse, recent or current opioid use. Sometimes they use microdoses with opioids at low dose, acute hepatitis, and liver failure. In conclusion, the hormones in the body really are a symphony. The adrenal hormones and thyroid hormones have a direct relationship and interplay with each other, with the conductor of the hormone symphony being thyroid. There's a lot of therapies, as you can see, that are available to look at the adrenals. There's a lot that are available to look at thyroid. But if both thyroid and the adrenals are not functioning perfectly, fix the adrenals for 6 to 8 weeks, then go back and look at thyroid. Access Medical Lab does measure all of these things. They do salivary testing, where they look at hormones from A to Z: estrogen, progesterone, testosterone, DHEA, cortisol, melatonin, and more. And again, I do like to get the 4-point cortisol level. And I love the little graph that comes back on it, because it's so easy for my patient to understand when they see that graph of 8 in the morning, noon, 5 p.m., and 11 p.m. They do have LMS, MS difference. It does matter how they test the hormones. And reverse T3, I really am probably beating a dead horse, but it's imperative to measure reverse T3. They do have LCMS-MS testing, which is the top of the line. There's their complete thyroid panel, which does include all the things we mentioned today. So thank you very much. I hope this has been a bird's eye view looking at the relationship and balance between cortisol and looking at thyroid as well. And now we will go ahead and take some questions.
Dr. Smith, thank you so much for that presentation. We had more questions during that presentation, I think, than we've ever had at one of our sessions. So love the engagement from everybody joining us, and thanks again for joining us. So I'm not sure, and to be honest with you, how much time do you have right now? Because we got about 60 questions.
I'm actually happy to go on at least for half an hour,
Okay.
because I think it's important that these two systems are so key. We have to be able to answer some of these questions.
Yeah, absolutely. Well, perfect. Well, with that, let's not waste any more time, and let's go ahead and jump in. And just so everybody in attendance is aware, we're going to go ahead and go through everything just chronologically. So first question that we had in the chat was, is there anything specific you noticed that causes hypothyroidism without being diagnosed or having any trouble as children? Example, excessive exercise, inaccurately prescribed prescriptions.
It's usually a mixed bag of things. It truly is. When people aggressively exercise, meaning 7 days a week, pumping iron, etc., then they do get deplete in those nutrients I talked about for the mitochondria. Mm-hmm. So even if my patient's 24, if they're a world-class athlete, if they're a marathoner, they're exercising aggressively, all those nutrients, the CoQ10, the lipoic acid, the doses I suggested, I give those as well. And then you don't end up having a thyroid problem usually.
Okay, perfect. How do you understand what are the causes of low free T3, but all of the other thyroid lab markers are normal? Which nutrients are for T3 versus free T3? They've tried SE, zinc, or other standard T4 to T3 convert protocol, but did not get good results. Wondering if you can provide any other insight beyond standard protocols.
Well, that's a great question. It's a really good one. No one's actually delineated out which of the nutrients specifically help with T3. But if I would choose one thing that I would look at, and we talked about medicines and all those things, it would be abnormal cortisol. Mm-hmm. I would go back and fix that first, then go and look at the other things as well.
Great. What's your experience using 7-keto DHEA versus DHEA?
7-keto DHEA, for those of you who do not know what it is, okay, is when the keto group is put on DHEA, then it doesn't make testosterone or makes very little. Remember, DHEA normally makes testosterone and estrogen both. So we use keto DHEA for people that are acne prone, because it makes less testosterone. We use it for people with normal testosterone and for people with high testosterone. So honestly, I've never used keto DHEA in a male. I've only used it in women. I'm on keto DHEA because I have normal testosterone. 1/2 of women will have normal testosterone through the rest of their life. I will be 68 this summer, so my testosterone is not going to change. It's going to stay dead center of normal on my saliva test. So I am acne prone, so I use the keto form myself, which, believe me, is much better for acne and all those other things.
Great. What is the best time of the day to supplement with DHEA? Is it like thyroid in that it can be taken by itself?
It can be taken by itself. I do suggest that people take thyroid and DHEA both in the morning. Okay. But DHEA can be taken with anything, unlike thyroid, where you should not have any food, supplements, or anything an hour before or an hour after taking thyroid.
Perfect. And then we've got a opinion question on nomenclature. So how do we, there's my dog. Sorry about that. Scared me. 1 second, y'all. Apologies about that.
I love dogs. What kind do you have? Oh, I love your dog.
This is my boy Cannoli. Apologies to everybody. He was just saying hi to just strangers on the street. So getting back into the nomenclature question, and apologies about that again. Are we still calling it adrenal fatigue? I've heard arguments that this nomenclature is overly simplistic. What is your opinion?
Well, certainly, to give credit to James Wilson, who is my contemporary when I first started out. Dr. Wilson really discovered all this. He did all the research. So I always give him credit by calling it adrenal fatigue. When it comes to billable codes, however, which is if you take insurance in your practice or your pharmacy, then hypoadrenalism or hypocortisolism would be the appropriate terms.
Okay, perfect. What is the DHEA level in serum that you supplement?
DHEA, I don't do serum testing in.
Okay.
I honestly don't do serum testing for estrogen, progesterone, testosterone, DHEA, or cortisol. So I can't answer that. I haven't done a serum test, I think, ever in 28 years.
Oh, wow. Perfect. So the next one is lowering cortisol levels for those who constantly see hypersensitive spike. Would you ever prescribe a CBD?
Yes, you can prescribe CBD. And for those who are interested and you don't know a lot about it, A4M is running the very first, and it's going to be phenomenal, module on cannabinoids in Hollywood, Florida next month. I'm taking it myself because I need to know more, but there's really no test yet to delineate whether it's going to work or not. So in my personal practice, I found about 50% of people benefit from CBD, and the other 50%, it does nothing. It's not negative. It just doesn't seem to help.
Yeah, perfect. And looking forward to seeing you out in Hollywood, Florida next month.
Absolutely.
Wonderful. So the next question would be, when you see a very high or very flat cortisol curve, can you start with adaptogens first before doing a workup for Addison's or Cushing's?
Well, you don't have to do a whole workup for Addison's or Cushing's unless you see that the DHEA is low and all 4 points of cortisol are low. If they're all low, then you do have to rule out Addison's or Cushing's, and you do need to get an ACTH, you do need to get an aldosterone, refer out to endocrinology to do an ACTH stimulation test, et cetera. And the same would be true if DHEA and cortisol are high. You do have to rule out an adrenal tumor. So sometimes there's more that needs to be done. But if you have that mixed picture, where cortisol's high in the morning and it may be low at noon, then those people don't really have adrenal fatigue. So you wouldn't start with an extract. An extract is only for people that have actually truly low levels.
Okay, perfect. So the next question is, will DGL not work for hypoadrenalism?
DGL does not work for it. Okay, it's great for the gut. Okay, but not for this purpose.
Okay, wonderful. How do you taper dosing Cortef on weaning?
That's another great question. It is done over a month. So what I usually do is I stop the 2.5 and wait about 5 days, and I cut the noon from 5 to 2.5. I wait about 5 days. Then I cut the morning, which is 7.5 to 5, and follow thereafter.
Perfect. Do you give most post-menopause hormone replacement?
Everybody who knows me knows that I am pro hormones. At the age of almost 68, I could not travel the world and speak. And I mean, in 2019, I spoke on 4 different continents. I could not do that without my hormones. Okay. That is just said and done. Am I ever going to stop them? No. Do I ever stop them in my patients? They're lifelong. The only reason to stop them is if they develop breast cancer. We're about to publish our trial, and it will come out this year. We actually did a retrospective study of our entire trial of all of our patients, and we've had no breast cancer patients on bioidentical hormones. But there's a caveat to that. We use physiological doses and we use saliva testing. We do not do serum testing. When you put the hormone on the skin, it does not show up in the serum. Again, if you put the hormone on the skin, it does not show up in the serum. We actually just completed a pilot study on that, which if I get time will come out this year, if not next year.
Amazing. That's super exciting. And just a quick side note, y'all, I know that it's at the hour right now, so if you do have to jump, no worries. We will be sending out a recording of this presentation along with the Q&A and slides. So if you have to jump, no worries. We'd love for you to stick around. But let's just jump right back into the Q&A. And Dr. Smith, let me know when you are running low on time. So the next question would be, how does the cell danger response fit in here?
I'm sorry, you cut out there.
Oh, no worries. How does the cell danger response fit in here?
The cell danger response, it can be due to many things. Some of it is related to infection. Some of it is related to toxins. Some of it is related to more of an inflammatory response. And some is related to mitochondrial dysfunction. So like everything else in a functional anti-aging precision medicine approach, we look at the cause of the problem and not just treat symptoms.
Perfect. Can someone have high blood pressure with hypothyroid?
Yes, absolutely. Absolutely.
Great. Straightforward answer there. How do you explain someone who has many of the symptoms of hypothyroidism, but their hospital lab tests always come back normal?
Those people, generally, you miss something else in, and it's more common than you think. So first of all, there's normal labs and then there's optimal. Today we discussed optimal, where the upper limit of normal would be TSH, and the free T3 and free T4 would be dead center of normal or slightly above. A lot of times reverse T3 has not been looked at in those cases. A lot of times thyroid antibodies were not done. Many times looking at cortisol was not done. The mitochondria was not done. They didn't look at nutritional depletions. They didn't look at phthalates. They didn't look at lead, mercury, and cadmium. And fortunately, all of us know to do all that.
Okay, awesome. How do adrenal extracts work if they do not have active hormones?
That's a great question. I don't know the answer to that. So that's something I'm going to put down and look up. So I'm going to get back with you guys if I find out, because honestly, no one's ever asked me that. So yeah, I'll get back with you on
that.
It's a
question when the expert doesn't necessarily have the answer, and that's the perfect answer to provide is something that you'll find the correct answer to provide before saying anything wrong, right?
Always.
Always. Just take that note for life. What is the preferred substitute for an adrenal extract in vegetarians and vegans?
That one's a hard one because there really isn't. So if someone's a true vegan, then usually I skip the extract part and then I go to licorice instead, along with obviously the multivitamin stress reduction techniques and all those other things.
Great. So in response to the connection between hypothyroidism and eating disorders, would you expect a correction of hypothyroidism to correct the eating disorder behaviors? And then can you elaborate on the relationship between these two?
It will, in many patients, improve it. It may not fix it because there's other things involved, like neurotransmitter function. So in a lot of these patients, I do neurotransmitter testing as well. Almost all these patients also have gut dysfunction. So I do a gut health test as well, because they're all tied together. So in those patients, they end up getting all of it. Some of them also have Lyme. Some of them also have toxic mold syndrome. So I start with one thing, and that's the second clinical pearl for today that's really important. Fix one thing at a time. If you try and fix too many things at a time, the body gets confused The patient does too. So sometimes I may order 6 things knowing they're all positive, but I'm not going to fix the hormones and thyroid and their toxic metals all at one time. I leave a gap of 4 to 6 weeks with each.
Great. How do we treat high reverse T3?
I just went over that. So please follow what I'm sorry if you joined us late, but I just went over that and that's in the slides.
Wonderful. And just so you guys are all aware, we will be sending out a copy of the recording in the slides. So what do we have next here? What type of fasting and how long will decrease T3?
That's another great question with a lot of people doing intermittent fasting. And then that refers to another hormone, insulin. Insulin is made pretty much before 10 a.m. in the morning and about 5 to 6 p.m. If you don't put food in before 10 in the morning, and if you eat too late at night, it teaches insulin to work ineffectively in the body. So sometimes people don't realize that when they do intermittent fasting at the wrong time, and then their insulin starts climbing, but then it negatively impacts thyroid and adrenals. So all of them get negatively impacted if people don't fast correctly.
Yeah. Would ALA be helpful for autoimmune hepatitis?
Yes, it is actually very helpful for that. And the dose is 300 to 400 milligrams.
Perfect. What method do you use for the, oh, this is, okay, Dr. Smith, this was a question that probably got asked 50 times in the chat. What method do you use to measure iodine? What do you use to test iodine?
I know there's a lot of discussion on this. I've always done the same thing. I do a urine test, and I honestly believe that is the most accurate method.
Okay, beautiful. Well, there we go, people. Urine tests. So how do ADHD medications affect cortisol? And if a patient needs to continue, should adrenal support be used?
ADHD medications can negatively impact neurotransmitters, epinephrine and norepinephrine, and some others, along with drive up cortisol. However, if you balance the rest of the system and the patient's on Ritalin, then the body will accommodate for all of that and settle its own self down. Remember, the body heals itself in many cases.
Yeah. In your experience, are antidepressants common to cause hypothyroidism that didn't exist prior to the prescription?
They can. I don't know how common it is, but they certainly can cause it. It's kind of a paradoxical thing since one of the symptoms of hypothyroidism is depression.
Yep. So I'm just getting all these questions in order. So that is why there's a little pause between them. So can sublingual hypothyroidism result in myoclonic jerking of the legs in elderly? Anything else that comes to mind for this condition besides low iron?
Low iron would certainly be one reason. Low magnesium is probably the second most common, and everything else thereafter.
Okay. Just a clarification question here. What is TMO level?
Oh, trimethylethanolamine. And that is, TMAO is a serum lab test. And it should be done in anybody that you're considering giving choline in as a supplement, L-carnitine, and really for anybody's overall health. We used to say way early on that people that had high cholesterol should not eat red meat and should not eat egg yolks. That's not true. Only people with high TMAO. So those people should not eat red meat, should not have egg yolks, should not supplement with choline, and should not supplement with L-carnitine. Some of that abnormality is genetic. However, some of it is from the gut. So if you fix the gut, in some patients, it may come down. There isn't anybody in my practice that I haven't done a gut health test on. There's no one I haven't done thyroid studies on, and there's no one I haven't done a saliva test on.
Great. How would you determine which patients get both T3, T4, T3 or T4 alone based on lab changes?
I actually really do go according to lab. If the lab shows me that the TSH, for example, is 2.5, and we measured iodine, it was normal, and selenium are normal, and I'm going to give thyroid. If the T4 is low and the T3 is dead center of normal, then I'm only going to give T4.
Perfect.
And I dose according to how off it is in the labs.
Do you have any supplements that come in an all-in-one pack for mitochondrial dysfunction?
I do. Actually, there's a company that makes that. And so if you email me, I'm happy to give you the name of that company and their rep can call you.
Perfect. And I will be sure to send out your email because that was another very common question that we had in the chat when you dropped your email. Don't worry, I'll send out that contact after this presentation so you will all have access to it. So a couple last questions here would be, what about patients with thyroid cancer and subsequent thyroid removal? Do you suggest the same protocols of supplements?
No, and that's a hard one. Because they've had thyroid cancer, the endocrinologist honestly believe they should only have T4. And I want to say that straight away. I'm not sure I agree with that. I'm not an endocrinologist, although I do have a certification in endocrinology from the University of South Florida College of Medicine, but I'm not an endocrinologist, okay? So I usually won't counter the endocrinologist unless the patient is really sick and I see that the free T3 is low. I do what every practitioner should do, is pick up the phone to the other doctor. So I call the endocrinologist and say, hey, this is what I'm finding. Is it okay if we consider giving T3 in addition to that T4? But the standard of care everywhere in the world is if it's thyroid cancer, it's T4 only. That does not mean, however, that I have not given T3. I have, but I do it in conjunction with the endocrinologist.
Great. So an LDN question here. LDN is not widely prescribed by doctors. Any advice for clients or patients interested in trying LDN?
Absolutely. Read the Townsend newsletter. I just wrote an article on LDN, and I went through LDN from A to Z because it is a game changer. So I discussed the use in different diseases and all the different diseases you can use it in. So that will be in either the June or July issue of Townsend, and that will give you the most comprehensive look at low-dose naltrexone.
Perfect. Keep an eye out, everybody. How long did you prescribe or rather give ALA to cure that Hep C case?
I'm sorry, say that again?
How long did you give ALA to cure the Hep C?
ALA is for the rest of her life, and her thyroid is the rest of her life as well. Now, I did back her down to 600 milligrams a day instead of BID. And the reason is no one knows if you can stop it or not. She's a nurse, and we got such a really good response. I've just kept her on 600 milligrams a day.
Great. So we have a scenario question here. There's a patient with ETAOH and caffeine addiction. Would you start on cordyceps and ashwagandha? This word always tricks my tongue. Ashwagandha while awaiting lab results.
I usually don't start much of anything without labs. For those of you who know me, you know I'm probably the most conservative professor out there anywhere who's taught for anybody, but it keeps me out of trouble and it keeps my patient out of trouble. I like to look at labs for everything.
Mm-hmm. Which is better to test in saliva, DHEAS or DHEA? Well,
saliva testing is the DHEAS level. So DHEAS is the biologically available form, and that's what you get when you do saliva testing of all those hormones, is the free amount of hormone.
Perfect. And let's just finish up with a couple last questions. Would you treat Lyme disease as a mitochondrial disease?
Yes.
Great. And then what is the right way to fast for adrenals?
Again, there's a lot of different discussions in the medical literature. Because I do so much work with hormones, I really believe in, if you're going to do fasting, that you don't eat after 7 p.m. and then you start eating again at 9 a.m. in the morning. And that way you don't negatively impact insulin, which then will negatively impact cortisol and thyroid.
Beautiful. And then our final question is just in regards to heavy metals. What is your protocol for clearing heavy metals?
Well, that depends, okay, on really what metal we're talking about. So to be very brief, because my MPH is in toxicology, okay. So when you look at clearing cadmium and you look at clearing mercury, the most commonly used substance is DMSA, which can be given orally. And there's different protocols. If you'd like mine, then just email me, okay. Also, A4M does offer a whole toxicology course run by Dr. Lynn Patrick, who's absolutely a fabulous naturopath who really does all of this, and Dot Merritt, who's a fabulous physician. From the viewpoint of looking at lead, it's a little trickier. It does require, if it's really high, IV EDTA. However, Microbiome just came out with a new product with great clinical trials 2 weeks ago that actually is a probiotic that increases the elimination of lead. So I have started using that in my patients. So I'm happy to follow up and let you guys know how well it goes.
Wonderful. Well, Dr. Smith, thank you so much for your time this afternoon. This was one of the most active sessions that we've ever had with all the questions in the chat. Thanks everybody for joining. Do you have any final last words for the individuals that are still with us?
Well, number one, thank you, Rupa, for the opportunity.
Absolutely.
Number two, thank you, Access Med, for the opportunity as well. And number three, thank everybody for attending. It is important to look at salivary testing for all the hormones. It is important to do complete thyroid testing. And I did measure or mention insulin. It is part of the hormonal symphony, as are the sex hormones for both men and women. You can't forget any of them, because you don't get it right if you leave something out. So thank you very much.
Yeah, and honestly, thank you so much. Just the love that you're getting in the chat right now. Clearly a very, very valuable presentation, which is why we had over 1,000 people register for it, which is amazing. So, for those of y'all that are able to stick around, what I'm going to do next, and Dr. Smith, you're welcome to stick around as well or hop off, but I'm going to show everybody who's able to stay with us how to order some of the tests that we talked about today directly from Rupa Health. So with that, let's just jump in. So if you're joining us today on this presentation, you might be familiar with Rupa, you might not be familiar with Rupa and who we are, what we do. The way that I really like to describe what Rupa Health is as a functional medicine platform. What we've done is designed a site and a software that is created to make life easier when it comes to lab testing. So the first thing that we found is that there's a lot of course, pain points when it comes to ordering tests. Most practitioners have 5, 10, 20 different accounts that they use to order all their tests. So we've aggregated over 25 different labs on our platform, allowing you as a practitioner to have one account and order everything in one place without having to go to each individual lab to make those tests, of course, including Access Medical. Beyond that, of course, you're able to track all your results in one place. So let's see how easy it is to really order these tests on Rupa. So all we need to start an order on Rupa Health is the patient's first name, last name, and email address. From there, we're able to jump into the order screen here, and straight away, it'll just give us access to all these different labs at our fingertips. So once this loads up, you'll see first and foremost at the top that we can actually create custom bundles. So if I want to create a custom bundle, which is a set of tests, a set of blood panels, a combo from any one of the labs that we work with, I can just go ahead and have that at my fingertips. And that way it's one click, and all the labs that I'm looking to order from today's lecture, for example, can be added right into my cart, right? So here's an Access Medical bundle that I created just straight off the bat. One click, 3 different tests ordered without one click of a button. Below that, I can create a favorites list. So individual tests that I want to commonly order from different labs, I can put a little heart next to it. And let's say I want to order this thyroid comprehensive panel from Access, along with maybe another test from another organization. Again, I have this all at my fingertips, just with one click of the button without having to go to each individual portal to do so. From that, it's as simple as clicking send a patient. And honestly, that's how easy it is to order a test from Rupa Health from 25 different labs all in one place. The way that we generate our revenue is simple. The cost of the tests are the exact same cost that you would get having an account directly with any of the labs. We charge a simple 7% processing and ordering fee on each order, and that's paid for by whoever's paying for the test. So what I mean by that is if you're a practitioner and you're having us bill the patient directly for the cost of the tests, which honestly is what the majority of our practitioners prefer to do, then the patients will be the one absorbing that cost. For you, Rupa Health will be a free account to use. You go to rupahealth.com, sign up for free. You can create an account with us in a matter of seconds and have access to a ton of different labs. Now, note that Rupa is currently only available within the United States. So if you are international, let us know. We're aggregating a list of different countries that are interested in working with us, but right now we are only within the US and only within 47 of the 50 states. So the states that we're not able to work in right now are New York, New Jersey, or Rhode Island. But keep in mind, if you are interested and you do order from multiple different labs, of course, including Access, feel free to reach out if you have any questions. Now, beyond just a place where you're able to track and manage and send your results out, Rupa has built an end-to-end patient solution. So as soon as you do place that order on Rupa Health, we can effectively take it from there. So we can bill the patient directly. We offer multiple different payment solutions beyond just cash and credit. We can accept HSA, we can accept FSA, and we can even set up a 3-month interest-free payment plan with the patients to pay for these tests. One of the ways that Rupa is lowering the barrier of entry for your patients to get access to these oftentimes very expensive tests, right? You can also have the option of paying for the test yourself. So that is an option there as well. From there, we'll send over FAQs, instructions, oftentimes videos on how to take the test to your patients directly. We'll manage any support questions that they might have. If you're working with an access test, for example, that requires a blood draw, we'll go ahead and help your patient coordinating that blood draw as well by sending over options based on Access's current network of phlebotomists. But let's say that your patient wants more of a white glove experience, they can reach out to us and our team, and we can help send over additional options to your patient. Let's say, for example, they want a mobile blood draw. We'll send over options based on their zip code to see if there are any available options in their area. From there, we'll follow up with the patient. We'll manage any specimen issues should those arise. And then from there, you're alerted as the results come in. So think of Rupa essentially as an extension of your business. The place where you're going to be able to come and place your orders for all your tests, have your patient experience and all that support taken care of so you don't have to, right? Basically freeing up time for you to focus on growing your business. And then you're alerted as the results come in. You're able to view and track the status of all of your orders in one place. So I can click into an existing order and see exactly when the specimens arrived at the lab, when I can expect them to come in. And once those results are in, you're able to view all them directly within Rupa. And we are actually even integrated with a couple EHRs, which is pretty great. You're able to download them. You can send them to the patient. You can schedule a clinical consultation should you need some assistance interpreting these results. And you can even view that requisition virtually. So with that, that's kind of the core of Rupa, right? The place where you're going to be able to come and order your results, but you're all participating currently in a huge piece of Rupa as we continue to grow. And that's actually education. So you're all actually currently within a Rupa University session. So Rupa University is a series of live classes that we host on a weekly basis. Of course, this week with Access Medical and Dr. Smith, where we'll host labs that will come in and talk about their different tests and how to interpret them and basically the use cases, the valuable education that is so important within the functional medicine landscape. There's so many different tests that are coming out. It's constantly evolving and growing and improving. And Rupa Health wants to be a core component of that education moving forward. So join us on a weekly basis for these types of sessions. They're every day or every Wednesday at 11 o'clock Pacific, 2 o'clock Eastern, and they're free to attend. Beyond just these live classes that we host, we also have some other cool things. So things such as the podcast that we host with Dr. Carrie Jones. If you're familiar with Dr. Carrie, she's amazing. So we host a podcast on every week. I believe there's new episodes released. We have a magazine as well. So you can always come and look at these different articles that we're publishing. Again, providing education, even the Lab Essentials Bootcamp. So the Lab Essentials Bootcamp is actually something that we're partnering with Dr. Dan Kalish on, where you can come and get basically a rundown on how to interpret the GI map in Dutch Complete. So this is, I believe, a 6-week bootcamp that we'll be hosting alongside Dr. Kalish, where you can register today for $2.99, sign up, and then you'll be able to continue to learn how to interpret these important tests. So with that, y'all, to recap, Rupa Health is a platform around functional medicine that's designed to make life easier in regards to not only your testing, but a place where you can come and continue to learn. If you do have any questions, please feel free to reach out to me directly by email. I'm going to drop it in the chat right now. It's just adrian@rupahealth.com. More than happy to schedule some time with you, as well as, go through how Rupa can help benefit and fit specifically within your clinic, things of that nature, all super important. So I actually have about 5 minutes before my next call, so I'm going to scroll through the chat. I did see some questions that come in. So let's see here. Let's go to the very top. So do the patients get the results to us first? So you have full control of how the patients receive the results. So they'll be sent directly to Rupa. There is a setting that you can enable that will allow you to have just the results sent automatically to the patients. Most practitioners prefer to not have that, but we won't send the results to your patients without your permission first. And then which EMRs do we integrate with? So currently we're integrating with OptiMantra, as well as Practice Better, as well as there's another one that's escaping my mind right now. So let me follow up with that final one. Do you still have to set up accounts with each company? No. That's kind of one of the beauties of this platform, right? Setting up accounts with all those different companies is a pain in the butt. And so with Rupa, you simply need to create one account with Rupa, and that's it. We'll set up accounts with all the organizations. Now, keep in mind, with our platform, we aren't the ones sending the test directly out. We're still creating those accounts on your behalf with these organizations. So with that, as long as your license type allows you to order directly from those labs, you'll be able to order from those labs on our platform as well. Can patients use insurance? So at this time, there's no way for patients to use insurance directly on these tests, or at least a lot of these tests. But what we do have within our solution is the ability for you as a practitioner to add ICD codes. And from there, once you add those ICD codes to the order, we'll go ahead and send the patient a template and walk them through how to create a super bill for reimbursement from their insurance. So Erica, my patient got her results before I knew about it. Not sure if there's a setting to turn it on or off. So yes, there is a setting. You can turn it off. So that setting itself is never enabled. There is the chance, and actually, unless that setting is enabled, that wouldn't happen unless the patient has an account directly with the lab. If the patient maybe has an account with the lab as the patient, then there's the chance that that email matches up with their account and the lab would actually send the results to them. But Rupa will never send the results to your patient without your consent. Carrie, thank you so much. Love the shout out. So our lectures at Rupa University are available to watch for patients or only for providers? Only for providers. So in order to have an account with Rupa Health, you actually do need to have, at this time, an MPI number. So Rupa University in the tab that I showed you before is only available for practitioners who have an account with us. How long until, ooh, I love this question. So this question is how long until Rupa allows non-licensed practitioners to order labs? So what we are creating here at Rupa, and unfortunately it has hit a bit of a speed bump in terms of when we hope to have this program out, is a program called Physician Authorization. Physician Authorization is a program that's designed to allow practitioners whose license types might be limiting in their ability to order tests, right? This isn't going to be available to just like anybody, so don't worry. Rupa's not just going to allow any, Joe on the street to place an order on our site. It will only be for practitioners who have specific certifications to order these tests. We're doing that by bringing on and partnering with an MD who will sign up on requisitions. Now, right now, the time frame on that is we're hoping by May. So just a couple months away. Please hang tight with us, and we appreciate your patience here with this program. So notes and everything like that, don't worry, y'all. We'll be sending out a recording of the session itself along with the slides. And then how do patients request payment plan? They would reach out directly to our team. So what happens is when you send that order directly to the patient, I can actually probably show you. When you send that order to the patient, they'll get an email that looks just like this. Dr. Adrian Martinez has ordered these tests for you. From there, they can view those results and pay. It'll open up a screen that allows them to pay for the tests. They'll enter in that information. And if they do decide to go with that pay in 3 installments, they simply just click a button there and they'll be able to add their payment information. So we make it as easy as possible. And again, there's no interest there. So it's interest free. They're paying it, and the tests themselves are actually sent after the first payment is received. So we're not waiting for the entirety of the bill to come through and be paid. We'll send those results or those tests out after the very first installment. And you'll notice here that will provide additional information if there is a blood draw required. So with that, y'all, I do got to jump, but thank you so much for joining us. And, those 85 of you that are able to stick around and watch this quick presentation, provide questions, all that. It makes my day, honestly, hosting these types of sessions and being able to be a resource for all you. So again, my name's Adrian. If you do want to set up a call with me or have any questions, here's my email. I'm dropping it one more time in the chat. Additionally, look out for a couple things. I'll send a follow-up email after this conversation, just like a follow-up automated email. And if you have any questions, reach out to me there. And within the next, say, like week or so, give our team a little bit of time to edit the video. We'll send out a copy of the video as well as the slides. So if you need anything, let me know. And again, I appreciate you all so much for sticking around. Have a great rest of your Wednesday.